So welcome everyone. Today's our point of discussion would be small cell lung cancer. Let me share my screen first. So I hope my slides are visible. So today our topic of discussion, small cell lung cancer. So at first, I think that we'll try to cover it in a single day, but suddenly I found that it is quite impossible to cover small limited stage and extensive stage in a single sitting. So today we'll try to cover only the limited stage part, and in the very next session with the same panel of experts, we'll try to cover the next part, that is the extensive stage of small cell lung cancer. So we have very distinguished panel of experts today. Brigadier General Professor Mohammad Kudrat Ilhai sir, Head of Department Medical Oncology, Cancer Center CMH. We have Dr. F.M. Kamaluddin sir, Associate Professor, Radiation Oncology, National Institute of ENT, Dhaka. And Dr. Mohammad Tawfiq Hassan Firoz Joy, Assistant Professor, Radiation Oncology, NICRH. And Dr. Jahangir Alam, Medical Oncologist, National Cancer Institute, Mohakali, Dhaka. So let us start with a very common case. That is usually we encountered in our chamber. 56 years male smoker patient presented with cough and shortness of breath. After several investigations, a FNAC done at last from the lung mass, and it comes with squamous cell lung cancer. So I would like to ask the first question to Dr. Jahangir Alam. So how you will proceed in your chamber with such a case, Dr. Jahangir Alam?
Thank you, Dr. Shuman. This is a nice case. I would like to proceed a core biopsy, CT guided core biopsy from lung mass first, then go for staging workup like CT scan with
okay, Dr. Jahangir Alam. So you are not very convinced with this FNAC report, squamous cell lung cancer. So you will try to go for another core biopsy. So Dr. Joy, are you happy with this FNAC, or you have the same opinion like Dr. Jahangir Alam?
I go for core biopsy.
Okay, Dr. Kudrat Ilhai sir.
Definitely, we should go for core biopsy because FNAC should not be a diagnostic approach to comment on it, because we have to do many things later on.
Okay, so now at first we will try to get an opinion, particularly for these issues, because very frequently we are getting these sorts of report, and let us see whether this FNAC is enough for getting us this diagnosis. So before going to Dr. F.M. Kamaluddin sir, so let me give a brief, because the small cell lung cancer is a very well distinguished features. You know, there's a blue colors, high nucleus chromosome ratios, and sometimes if the FNAC says that it is small cell lung cancer, so do you think with a concrete diagnosis like a small cell lung cancer in these sorts of report, and sometimes we got that undifferentiated type of reports suggestive of a small cell lung cancer. So in the very two situation, whether you are opted for core biopsy or you have selected reports, whether you have got that undifferentiated cancer, this group of patients should go core biopsy, or if the histopathologist is confident about the FNAC report regarding small cell lung cancer, you will be very happy with this FNAC report. Dr. F.M. Kamaluddin.
Thank you, Dr. Shuman. The situation of, as you mentioned, the non-small and small cell is totally different. Cytology is most of the time is quite fair enough to give a clean-cut comment about a small cell lung cancer because of its distinct features of the small cell variety. So in most of the cases, we can, if it is a good yield cytology, that is FNAC, in small cell lung cancer, that can justify the diagnosis. When there is a controversy or there is a confusion, we can take the help of IHC, because if you have a cell block, we can do the IHC from the cell cytology. Yes, core biopsy is better, but it is not that mandatory like non-small cell lung cancer, because here we don't have a huge role of molecular testing like a big panel like non-small cell lung cancer. So a good volume, I mean, if it's a good quality cytology and if you are trustworthy pathologist, he or she can give you a comment on small cell lung cancer from cytology also. And if there is a confusion from the cell block, you can go for IHC.
Okay, so is there any condition, is there any kind of report whether you will opt for this core biopsy?
Yeah, when we are struggling, you know that when we are struggling that what type of diagnosis there, then we need a better tissue because we need to have much more tests for IHC. That is the situation. And sometimes, you know, neuroendocrine and this small cell, there is a difference situation arise, and there we need to go for that.
So okay, let me ask this the continuation of, please Dr. Joy, proceed.
So I will go for ISC because there is a big difference between small cell lung cancer and small cell lung cancer is also a neuroendocrine tumor, and carcinoid tumor is also a neuroendocrine tumor. So there is a lot of chance in our country there is a mix up between small cell and neuroendocrine tumor. So we should see the mitotic rate of this patient. So for seeing mitotic rate, I will go for core biopsy rather than FNSC. Number one,
Okay.
and number two,
Okay.
I'll go for immunohistochemistry also.
Thank you, Dr. Joy. So this is the scenario when the report is undifferentiated type of report. So we are talking about if the cytopathologists give a conclusive decision that it is a small cell lung cancer, probably we don't need further core biopsy. If this is undifferentiated type, in this type of report, we should proceed with core biopsy with all those of immunohistochemistry report. Suppose this report is undifferentiated carcinoma. So how you will proceed, Dr. Joy? What kind of immunohistochemistry you will suggest, or you will proceed with the so-called report addressed by the pathologist? So these are these panels. Are you happy with this? Or
No,
you
no,
have
no.
specific panels that you will address for this particular patient?
I will go for synaptophysin, chromogranin to differentiate from neuroendocrine carcinoid tumors, and TTF1 and cytokeratin to confirm the small cell. So
Okay.
I will go for this. And
so
also
you will,
Ki67.
Okay, so Dr. Joy, as you have already mentioned, that the carcinoid, this is also neuroendocrine variety. So all these stains are going to take uptake. So this is all neuroendocrine varieties. So whether you go for synaptophysin, chromogranin, it will take a little bit stain with these markers. So how we are going to differentiate whether it is carcinoid or small cell lung cancer?
By mitotic rate and cell proliferation index. In case of carcinoid tumor, mitotic rate is less than 2. In case of atypical carcinoid tumor, range is 2 to 10. But in case of small cell, that is more than 10. So
okay,
this is a big issue.
Very good, Dr. Joy. So is there any role of Ki67 to differentiate it in this scenario, carcinoid? All are neuroendocrine varieties with this small cell or carcinoid is there. So is there any role of Ki67?
Yeah, there is a role in Ki67.
Okay, so let me hear from our senior teacher, Kudutila sir. So is there any role of Ki67 to differentiate small cell lung cancer from carcinoid?
Ki67.
Yes, sir.
Yes, I think we can understand about the mitotic that is proliferative rate. So Ki67 has an immense role. If it is more, then we can say that it is a small cell carcinoma.
Exactly. Ki67, you could see that this is the NCCN 2022 version. You could see that all these stains are taken by neuroendocrine type of cancer. So this is not a very specific for small cell. So in this type of scenario, you could check the Ki67, whether if this is more than 50%, then you can guess this is a small cell rather than carcinoid. And of course, this is discussed by Dr. Tawfiq Hassan. He says that the mitotic index, yes, if the mitotic index is more than 10, then we can consider it as a small cell lung cancer. So all these tests are done. Finally, it diagnosed as a small cell lung cancer. So how you are going to stage up your patients, Dr. Jahangir Alam?
I will go for CT scan with contrast chest and abdomen, MRI brain, and if indicated, isotope whole body bone scan also.
So what does it mean, Dr. Jahangir, if indicated?
Indicated if localized pain or high alkaline phosphatase.
So if it is not there, so you are not going to check the bone scan if you are not going with the bone scan.
No, if no indication, no bone scan.
So if it is symptomatic only, particularly for this type of situation, you are going for this bone scan. Otherwise, you will happy with this CT scan chest, CT scan abdomen, and MRI, right?
Yes.
Okay. Regarding staging workup, Dr. Tawfiq Hassan Joy.
I will go for CT chest and abdomen with contrast, brain MRI with contrast. If brain MRI is not possible, then we go for CT scan with contrast and bone scan if needed.
Okay, so you were happy with Dr. Jahangir's alone decision.
Yeah.
So Dr. FM Kamaluddin sir, what is your decision?
So Shuman, in case of small cell lung cancer, this is a most dangerous tumor that we'll be handling. That they present with 25% plus patient with distant metastasis. So if possible, we will go for PET CT scan because we know the sensitivity and specificity is the highest. And even as we know that the highest percentage of failure of small cell lung cancer is the brain, and 6 to 10% of patients without symptom even have brain metastasis in small cell lung cancer. So we should complement PET CT with MRI brain, MRI with contrast. That will be not always enough because we know that PET CT have sometimes false reading about the bone metastasis. It gives false positive report. So if there is some question about the bone scan, maybe we will need to do some bone marrow biopsy also because the marrow invasion may be there because we know that it infiltrates the bone marrow. But in your country context, practically, we discuss all these things. Sometimes it is not possible. When patient refuse, then I go at least CT scan chest and abdomen with contrast and MRI. So this is, bone scan normally we don't do unless there is a symptom.
Let me hear from Pukuduthelai sir. So there are two opinions. One is preferred option, that is PET CT scan, and one is this that the resource constraint management like CT scan chest abdomen. So forget about the resource constraint. So suppose we are in a standard world. So in this context, what would be your staging workup, sir?
Standard world, we must go for PET CT scan and MRI brain.
Thank you, sir. So would you like to give any comment regarding the last word stated by Dr. FM Kamaluddin sir regarding the bone marrow study or bone marrow biopsy?
Yes, there is recommendation for bone marrow study also to see the metastatic workup. We can go.
Thank you, sir. So let us see who are those candidates when bone marrow study is indicated. So you can see this is all we have discussed so far. This is the CT scan chest, abdomen, pelvis, brain MRI is the preferred test. PET CT scan, definitely we should think when we are thinking that this is a limited stage disease and we are going to offer a curative intent treatment for these patients. So if we find finally, if all these tests give us a conclusive diagnosis that this is a limited stage disease, for the limited stage disease, we have some special investigations. That is the lung function test, as we know, we should do in any kind of setup when we are going to treat our patients with radical intention radiation therapy. Bone imaging, if PET CT scan is equivocal when, as said by Dr. FM Kamaluddin, and unilateral marrow aspiration biopsy in selected patients. So what are those selected patients? So those selected patients are those who have neutropenia, persistent neutropenia with thrombocytopenia. So I am sure in my practice life, I found very limited percentage of patients who has gone for this biopsy or bone marrow biopsy or bone marrow study for small cell lung cancer. So it's a new learning that if our patients presented with persistent neutropenia, with persistent thrombocytopenia, we can give a look whether this is bony infiltration or not. So I think this is a great idea to to include it as a staging procedure. So finally, all these tests are done, PET CT scan and brain MRI. It comes with T2N1N0, that's a stage 2B or limited stage disease. So regarding the staging management, so there are different type of staging management system. So that is the veteran system, that ISLC system, and very popular TNM system. So Dr. F.M. Kamaluddin, sir, particularly managing small cell lung cancer, which staging systems you should consider for as a familiar option? Dr. F.M. Kamaluddin, sir.
So even TNM is recommended, but normally still the limited stage and extended stage is quite good enough for us, because this TNM doesn't really make a good contribution to our treatment disease, because still we are following the limited stage and extended stage. So TNM is there, but following the criteria of limited and extended is fair enough to take a decision whether you are treating in which modality.
So in ISLC staging, if it is pleural effusion, if the total volume is enclosed by a portal, it is considered as a small limited stage disease. So in this tricky situation, pleural effusion, should you consider it is limited stage or extensive stage? What type?
There is big debate on this on small cell lung cancer, and you will find many discussion, but end of the day, they will consider it as a limited stage. Pleural effusion itself is not a contraindication of a limited stage, and it is not a contraindication to treat with a radical intent. And if you look at that, there is an indication that only in small cell that you can go for induction chemotherapy followed by chemoradiotherapy, I mean the radical treatment, but which is not allowed in small cell, non-small cell lung cancer. So in limited stage consideration, when there is a effusion event, that is not a contraindication to stage it as a limited stage. Unless it's expensive.
Sir, I have a question, sir.
Okay, yes. Okay, Dr. Joy. Please, Dr. Joy.
Sir, in case of site is proven that malignant pleural effusion, then it will be go extensive stage. Recent current NCCN guidelines says that malignant pleural effusions goes to extensive stage. Am I right, sir?
Okay, let me discuss with these issues. So I am coming with these issues. So Kamaluddin sir, if the cytology proves it is a metastatic effusion, so still it is in localized or limited extensive stage.
Yeah, if it is the, I mean, what Joy is telling, that TNM is telling that if it is cytology proven as positive, it comes to M1. But if you go to ILC, they are not telling that malignant effusion is not in extensive stage. They are still putting it in the limited stage. That is what the recommendation was, and all the trial that you will see that you will be discussing later on. The limited stage, they have taken the pleural effusion in the limited stage, and we are still basing on that.
So thank you, Dr. Kudru Tilhai sir. Suppose the patients after the staging staging operations, a limited stage disease, but a pleural effusion. So how you are going to proceed this type of scenario in this type of situation?
In small cell lung cancer, most of the cases we will think that it is limited stage disease, pleural effusion, as per the recommendation. So we'll treat the patient as per limited stage disease.
So for any kind of cytology, any kind of pleurodosis, any kind of pleuroscopy, thoracoscopy.
Yes. If the effusion is massive or moderate, then we'll go for tapping and also diagnostic purpose, and maybe we will go for pleurodesis also if it is malignant pleural effusion. But stage purpose, yes.
Okay, so if it is effusion, if it's a mild diffusion, you will consider it as limited stage and you will proceed along with the limited stage management plan, right, sir?
Yes.
Okay, so Dr. Jahangir, do you have any comments regarding these issues?
No, I agree.
Okay, but recent TNM staging that shows that if you have any effusion, you need to check whether it is metastatic or not. Because if it is metastatic, it is M1 disease, then the whole plan is total management plan scenario will be changed. I think it would be a good idea to check any kind of pleural effusion, whether this is metastatic or not. Probably this might be reactionary, but we need to check the pleural effusion, and after that we have to conclude that whether it is limited or extensive stage. So particularly for our patient, that is T2N1 and M0 disease, so we have several options we can offer, that is surgery, sequential chemo-RT, chemoradiation therapy concurrent with BID dose plus PCI. So Dr. Jahangir Alam, which one you should think that it is better for your patient?
If a performance status is good, I prefer CTRT BID plus PCA. If performance status is poor, then sequential CTRT surgery is no.
Okay, Dr. Joy.
I fully agree with Jahangir.
Okay, so chemoradiation therapy with BID plus PCI, right?
PCI. Performance
Okay.
is 1 or 2, we'll go for CTRT PCI. But performance status ECOG scale 3, 4, then I'll go for sequential CTRT.
Okay, so even 3 or 4, you will consider radical treatment. I hope.
Because
so you are not going to mention it. You are just trying to focus on the performance status. I got your point. So Dr. FM Kamaludin sir.
So Shuman, normally the recommendation is CTRD BID plus PCI, but what I personally practice, it is also the recommendation of TURISI trial, that I look at the volume. If the volume is quite big, the nodal volume is quite big, I use 1 to 2 cycle of induction chemotherapy. I try to reduce the volume to make the life easy for the patient and also for the doctor. Then I go for concurrent chemoradiotherapy, preferably BID, and then CTRT definitely. And then not only PCI, I also go for consolidation 2 more cycle, like the TURISI trial, because we need to finish the 4th cycle of chemotherapy of cisplatin topoisomerase, because we know that there is a systemic failure. This CTRT is taking care of the local failure. As we control the brain mets by PCI, we need to control the systemic failure by subsequent 2 cycle of consolidation therapy. This is how I try here.
Okay, so particularly for this case, this is not a big scenario. You can see that the T2 disease N1. So particularly for these patients, whether you will
concurrent chemoradiotherapy, I will not go for induction. As I told you, sometimes the location and the tumor and node is very nearer. So all through it becomes a big mass, or it is creating such an area that it can cause higher esophagitis. So that's why I shared this, because this is a learning that to make the tolerability easy, we are allowed to bring 1 cycle up front, so that if you can reduce the volume, then the tolerability becomes okay. And why? Because in TURISI trial, they have allowed 1 to 2 cycle of induction, and they have shown that.
So Dr. Kamaluddin sir, if you see there's the CONVERT trial, they have started the radiation therapy on 22 days. That means after 1st cycle of chemotherapy. And you can expect a patient with a small cell cancer, you can get a significant number of size reduction. Yes. So I think the CONVERT trial is fair enough. So I think we do not need 2 cycles of induction.
Yeah, CONVERT and TURISI both. TURISI, they have started on day 1, but some of the patients, they have given induction. CONVERT, they started intentionally. And CONVERT was a non-inferiority trial. Actually, CONVERT is a negative trial. CONVERT intention was to prove superiority over BID, but they failed. But then you will see that the dose, interestingly, when we are happy with 60 gray dose in non-small cell lung cancer, small cell being so much chemoresponsive, CONVERT uses 66. That is another interesting part. And even in TURISI trial, it was the 2D era. It was a 2D field, and CONVERT is a modern technique era. So using modern technique, higher dose, they failed to prove superiority over the 2D conventional therapy. So the CONVERT is a good reference, but not the best reference to take up if we can go for BID.
Okay. So, Manjur Kudutalai sir, so what is your decision, particularly for this patient?
My decision for this patient, I will give first cycle chemotherapy. Then on 22nd day onward, we'll go for CTRT, followed by PCI.
Okay. So it is really very nice to discuss in a academic area. So this is after giving chemotherapy on 22 date, we are going to give radiation therapy. But do you think it is really practical in a resource country like Bangladesh? So don't you find any challenge
Yes,
to put your
for
patient in such a tight schedule?
radiotherapy is, that's why I told, if we go for first cycle chemotherapy, then we can buy time. So at least 21 days I am getting. So we can manage it. But if it is not possible for radiotherapy, then we have to give chemotherapy only. But
then I am sure in sitting in Bangladesh, this is a common scenario for all of us. So if particularly for a private center, those who are getting their treatment in a private center, except those, and for most people, it is really very challenging to follow this schedule that 22 days we are going to give radiation therapy. In this situation, how we are going to manage our patients, that we really want to hear from you, sir.
it is very difficult. In that case, we have to follow chemotherapy only, because we know small cell lung cancer is very chemosensitive. So we'll give 4 cycle to 6 cycle chemotherapy if CT radiotherapy is not available.
Dr. Kamaluddin, sir.
So Shuman, there is two challenge. Normally, we should not go for fast cycle chemotherapy. It is not required because it has not shown any superiority. Number two, sometimes there is a funny challenge. So very good response is sometimes dangerous. We don't know where to treat. If we give 2 cycle chemotherapy, like non-small cell lung cancer induction, 2 or 3 cycle, then we will be struggling where to give radiotherapy. We will not find any area. And there is no rationale of giving the pre-chemo area. Then they used to say that assume where to give. That is a interesting thing. So if possible, start beginning, but it's a huge tumor. You can go for at least 1, maximum 2 cycle, depending on the response. But don't chase if it is not required. Because if you look at the timing, there is a NCIC trial of timing of radiation therapy in small cell lung cancer. They have shown that earlier the radiotherapy, better the outcome. It is an NCIC trial. They have shown that what is the timing. And they have definitely shown that the earlier treatment of radiotherapy gives better outcome than late. So we should not delay. If possible, we should start from day 1. If required, we can go for 1, maximum 2 cycle. 2 cycle is sometimes dangerous. So this type of tumor, we should not go for anything, because there is a chance after 1 cycle, you will not find anything to radiate. So better to start with this type of tumor, CTRT first.
Okay, so you are not going to consider this resource limitation. So by any means, you want to start the treatment as per the protocol, right?
Yes, because Shuman, this resource limitation we should not bring, because when we are talking about IMRT, VMAT, 3D CRT, and we are talking about resource limitation, when we are talking about PET CT and CT scan, then resource limitation. Yes, if there is a queue, say for example, what we are looking at survival. Out of 100%, we are looking at 25% survival. We'll lose 75% patient. So if you go somewhere in the name of resource limitation, then we are losing the opportunity. So I want to stick to the protocol as much as possible. If there is a situation where we cannot avoid it, that is a different thing. But in mindset, we should not bring that we are in a resource limited country, we cannot do it. We should change this mindset. That is my message here.
So intentionally, I raised these issues because this accelerated radiation therapy, you can complete this radiation therapy with 15 days. Probably it is going to lessen your burden in this setup. So I think there should be a mind setup that we should follow, at least in small cell lung cancer, particularly those are in limited stage. We should follow the protocol. We should not bring this resource limitation, particularly in this area. We should try to focus, because this is going to play a major role in the overall outcome. So all of us here decided for chemo radiation therapy concurrent with BID dose followed by PCI. So we have all those evidence over there. The CTRT is better than CT. early RT better than late RT, and as already Kamal Bhai shows, Kamal Bhai said that the early radiation intervention less than 9 weeks going to play a major role, and concurrent CTRT better than sequential CTRT. These are all the evidence, particularly for the limited stage. So OD versus BD, that the best survival result achieved with early BD concurrent CTRT. So I am going to show you the details of the study. So let us clear regarding this chemotherapy backbone. So all of us are very focused on the chemotherapy. So let us at first hear from our panel of experts what is their opinion regarding the chemotherapy. Dr. Jahangir Alam, what is the chemotherapy composition over here?
Chemotherapy composition or
yes, chemotherapy.
Common chemotherapy is etoposide cisplatin or etoposide carboplatin.
Okay, thank you. Dr. Jahangir, Dr. Joy. Chemotherapy.
Cisplatin and etoposide.
Dr. Kamaluddin sir.
So Shuman, there is a trial in small cell lung cancer head-to-head. They have shown that carboplatin is equally effective than cisplatin. So most of the trial is in cisplatin etoposide. So we go for cisplatin etoposide, but in any frail patient or compromised patient, to go with carboplatin etoposide is no harm, because there is a head-to-head comparison of cisplatin etoposide, cisplatin and carboplatin in a small cell that he has done equal.
Okay, so Kudutilai sir, in the 2DC trial, they have tried 4 cycles cisplatin etoposide. In the convert trial, they have both options 4 or 6, and in the total sample size, only 20% received 6 cycles chemotherapy. So regarding the chemotherapy cycles, 4 or 6 cycles.
I think 4 cycle should be the standard, but in some cases, maybe 6 cycle is required if the lesion is very big, that is T is more. In that case, 6 cycle may be offered, but 4 cycle is the standard, so far I know.
Okay, Dr. Jahangir Alam, 4 or 6?
No, I agree. 4 cycle is standard.
Dr. Joy?
4 cycle.
Dr. Kamaluddin sir, you have already mentioned that sometimes you consider for this consolidated chemotherapy. BID chemoradiation therapy is going to produce a pneumonitis. So after that, giving 2 more cycles consolidation therapy, don't you find any challenge?
There is a challenge, but Shumon, there is 2 things, as I mentioned, that why we are using BID. The backbone is the 2DC trial. And if you look at the 2DC trial, they have used 3 weekly, 4 cycle of chemotherapy. But one thing important, the dose are not the standard dose that is used in the 2DC trial. They have reduced the etoposide dose when they have used in concurrent setup. So this is definitely a challenge. And the biggest challenge of chemoradiotherapy in small cell lung cancer is the concurrent cisplatin etoposide or carboplatin etoposide, in compared to only cisplatin or teclicarbo in non-small cell lung cancer. But at the cost of what we are buying sometimes equal or higher survival than non-small cell lung cancer, which is quite interesting. So we need to take the pain of that esophagitis, and we need to get prepared for that and go for it. So that is the thing. And if you look at the 4th versus 6th cycle, there is a study that even in extensive stage, more than 4 didn't give any higher survival benefit. So that's why the recommendation is to go for 4th cycle, except very specific case where is extensively good response in extensive stage, that after 4th cycle you can chase up to 6th cycle, but not more than 6th cycle. So now the standard of care came back from 6 to 4, because 4 versus 6, there is a study like the Greek study, cisplatin, carboplatin, they have shared equal outcome. Similarly, 4 versus 6, they have shown beyond 4 doesn't give any survival benefit.
So regarding this concurrent chemoradiotherapy protocol, we can conclude that cisplatin etoposide is the standard, because most of the trials, that is the 2DC and the convert trial, they have tried this cisplatin etoposide. And it is now evident that a full dose of chemotherapy can be given very safely with this concurrent radiation therapy setup, even with the BID protocol. So no question about dose compromisation. And 4th cycle is fair enough. There are certain percentages of patients, if he is fit enough and you are very courageous to give 2 more cycles chemotherapy, you can offer. I really don't know whether these 2 cycles chemotherapy are going to give any advantage or not, but definitely you can try your patients. So Kamal Bhai or Kudutilai sir, any comment regarding this consensus?
Yeah, I
No,
think, sorry, yeah, Dr. Kudra, please proceed.
No, I have told it. The fourth cycle is okay, and what you have told is okay.
Kamal
So,
bhai?
Shuman, again, coming back that regarding the fourth cycle, if you look at the tourist trial, they have planned for fourth cycle. That was the secret why I was always chasing for fourth cycle. If you start and you will end up with the total fourth cycle. And why? Because, as I said, that we want to look at the local and systemic. And believe me, I have treated few patients with BID and cisplatin leukocyte. It is possible. It is a more a myth than that two-side BID concurrent. If we can treat nasopharynx with 70 gray concurrent, then consideration 3 more cycles, cisplatin leukocyte, cisplatin 5-FU. Why we cannot do it in lung cancer, I don't understand. Nasopharynx is more challenging. So there we are using it, adjuvant 3 cycle after 70 gray. So this is more a mindset, Shuman. So this is why I was telling that it is possible, just do it, the patient can go away.
Exactly, Kamal bhai,
Shuman,
what I want. Yes, Dr. Joy, please.
NCC 2021 suggests cycle for limited and
Yes.
only 6 cycle of extension. I think so.
Yeah, that we are
Okay,
discussing. 4th cycle is for limited. 6th cycle, 4th cycle is also for extensive. In limited
But-
case, up to 6th cycle. Even extensive,
No.
they are not telling that all cases should be treated with. Beyond 4th cycle, there is very minimum outcome in extensive also. We will discuss in the next session.
No, don't make any confusion. We are discussing here only on limited stage. And in limited stage, there are
It's
both
4
options for
cycles.
4 cycles versus 6 cycles. Because we are talking about this 2DC trial. But before going in details, Kamal bhai, let me discuss our real life experience. That is very interesting that treating few patients with BID, I found that the esophagitis or toxicity is quite less than the conventional radiation therapy, that is 60 or 66 day. So what is your experience, Kamal bhai? I found it's a little bit comfortable to treat these patients with this 15 days protocol, BID.
Shuman, as I told you, for me, it is not the BID, it is the cisplatin etoposide, which is the culprit. And when you go for full dose, one of my patients had a severe esophagitis, I remember. But most of the patient didn't have. Rather, I had the problem with the consolidation part, not during the chemoradiotherapy part. I struggled with the consolidation part, that they were struggling, and I had to take care of it. But believe me, there was no treatment break in any patient when I treated with BID.
Exactly. 3rd and 4th cycle completion is a little bit challenge, but completion of radiation therapy is not a challenge at all with this BID protocol. So here is the 20 years back, but still the backbone of small cell lung cancer management. That is the 2DC trial. You could see they have tried with 3 or 4 cycles chemotherapy, cisplatin etoposide, along with 45 gray, very conventional daily dose versus BID dose, 19-day full course treatment. But dose is here 45 gray. This is a little bit questionable dose. Why in a single OD dose, why the dose is 45 gray? But still, you can see that BD dose, 5-year survival rate is 26 versus a single OD dose 16%. So by giving radiation therapy, BID giving a 10% better survival at 5 years. But the real challenge was there that the 1/3 of your patients at that time need hospitalization for this esophagitis. Why? Because in 2DC trial, the treatment modalities for radiation therapy was a very older version, and it was on the 2D CRT mode. So here comes this newer version, that is the CONVERT trial. You could see that the question that was discussed in for the criticized group, particularly for the 2DC, that why the control arm radiation therapy was only 45 gray, why not it was a higher dose? So here comes with the beautiful design. You could see that the 63, 66, 33 with the same cisplatin etoposide dose versus 45 gray with the same chemo protocol. And here the criticized group got their answer. Still with the higher dose, the BID dose is a better player. You could see 5-year survival 34 and versus 31. And already Kamal Bhai mentioned that this convert trial design as a superior policy. So they tried to show that the single arm treatment 66 is better than BID dose. But ultimately, it comes with the equal result. So they fail to prove the superiority of this single arm treatment, single day treatment. And not only that, with the application of the higher technology treatment, that is the IMRT, that is the higher fusion of PET CT scan, you could find that this, even with the BID dose, the challenge esophagitis was quite minimized here over here. So after all, the convert trial, they have concluded that the addition-related toxicities were lower than expected due to the use of modern RT techniques. Survival in both arms was higher than previously reported. So 2DC, it was 5 years, 26, and convert, it is around 31 to 32%. But 45, but OD treatment did not result in superior survival or worse toxicity than BDRT. But those are the patients whom you cannot consider for BID dose. Definitely, single day radiation therapy is a valid options. But the standard of care is 45 day in 30 fraction. So these are the conclusion from this convert trial regarding the BID dose. Here comes the meta-analysis, including 5 randomized control trial, more than 1,000 patients, including the convert trial. And they have found that BD-CTRT improves overall survival. BD-CRT improved median overall survival 4 months. So no question about the BDRT right now after this meta-analysis. So now the question regarding the PCI. So I would like to ask this question to Dr. Jahangir Alam. All localized group patients, early stage localized patient, whether you go for PCI or not. Dr. Jahangir.
In limited stage, I will go for PCI after completion of primary treatment.
So in every patient, so in limited stage, they are at stage 1, 2, 3. So all those patients, when you are expecting a better quality, better overall survival. So whether you are going for this PCI to every patients, or you will select some patients for PCI or select some patients for not.
I will go every patient PCI for PCI.
So you will opt it for every patient for PCI. Dr. Joy?
No.
So then who are those patients?
For particularly for this patient, I will go for PCI. But in case of very early disease, that is T1, T2, N0, for this type of patients, I will not go for PCI.
Okay. Dr. Kamaluddin, sir.
So Shuman, why PCI? First of all, around 50% of the small cell lung cancer, they have metastasis in the brain. And if you consider the post-treatment at 5 years, it goes up to 80%. So majority of the failure post-treatment is in brain. But if you give selected PCI, this risk comes down to less than 5%. And meta-analysis have shown that there is a survival benefit of 5% by giving PCI at 3 years. So all these things favors giving PCI in a small cell lung cancer, but to whom? It is said that if there is a complete response or near complete response, then that patient is benefited from PCI. If there is no response, there is no value of giving PCI to the patient. So in small cell limited stage, most of the time we are getting near total or total response, so PCI is justified. The debate is with extensive stage disease. In limited stage, there is no debate now. It is established that we give 25 gray in 10 fraction to whole brain as a PCI to the complete response or near complete response.
Okay, so you don't want to discriminate your patient, so you want to treat as a whole limited stage disease, whether it is stage 1 or stage 2. If it is complete response or partial response, you will opt it for PCI. So could you tell us, sir, whether you are in the same opinion or not?
Same opinion, because the chances of metastasis is more, so we should go for PCI for this patient.
Okay, so Dr. Joy has some selection criteria. He opted for PCI only for those who are with node positive. If it is T1 or T2, he is not very keen for giving PCI. Okay, let's see. So you can see that PCI, major risk of bone metastasis around 50 to 60%. PCI reduced the risk of brain metastasis by 50%. And as already discussed by Dr. F.M. Kamaluddin sir, Operin et al., they have proved that 3 years PCI increase overall survival 6%. But the question comes when we are going to give this PCI. Dr. F.M. Kamaluddin sir.
So they said that after last intervention, it is the chemotherapy, minimum 2 weeks gap should be there between the PCI and the chemotherapy. Otherwise, it will cause a severe toxicity. So minimum 2 years, 2 weeks is the recommendation.
Okay, so there is a selection criteria for giving PCI. So you need to check whether there is complete response or partial response or whether it is stable disease. So when to check this status before doing this PCI? What is the time frame? Dr. Kamaluddin sir, when we are going to check this status by CT scan or any kind of modalities?
So once we finish our treatment, say if we have planned for chemoradiotherapy and then chemotherapy, fourth cycle we finished it, then go for 2 weeks, finish it, then take 2 weeks, then we do the imaging, we assess that there is the response, then we decide that we go.
Okay, so after
consolidation, we should.
Right. After completion of the whole treatment protocol, and then giving a certain times, probably 2 weeks, then we should check all the parameters. So even in these conditions, you try to check the brain MRI, CT chest, CT abdomen, all are now, or you just happy with the CT scan chest?
Normally we do with the CT scan chest. Normally we don't go for brain MRI because at the base we have done all these things. We don't go, but in other way, when I'm going for PCI, the scanning of brain is done. It is not MRI, but CT scan is done. For abdomen, if there is no symptom, normally I don't do.
Exactly, the guidelines are saying that the selection criteria is the response evaluation by lung. So we need to check only the CT scan. So if it is at least stable disease, we can consider for the PCI. So Kudratullah sir, are you in the same line or you want to check your patients in a different way?
No, in the same line for the radiation.
So the standard dose 25 in 10 fractions. But again, back to Dr. F.M. Kamaluddin sir. Dr. Joy is a little bit skeptical regarding this radiation therapy PCI for some group. So definitely he has some reason. Limited stage, you can expect around 30% of your patients is going to survive. So giving this PCI, whether these neurocognitive functions might not be a very big player.
Yeah, it can be, but you look at the dose. It is not 30 grain 10 fraction. We have enough data of neurocognitive effect with 30 grain 10 fraction when we do it for brain metastasis. But for PCI, the dose is 25 in 10. Why? Because they have reduced the total dose from 30 to 25 for considering these things. And today, it has shown that if you look at the risk-benefit analysis, that we are getting more benefit than the risk. Neurocognitive effect is not that much like 30 in 10, in 25 in 10. But the benefit is much better here because we are reducing the risk. If there is a big survivor, the risk of brain mets is more, and which is coming down to less than 5%. That's why trade-off, we go for PCI, even there is some risk like that.
Okay, so the study says that even with this dose 25 in 10 fractions, the neurocognitive impairment rate is around 50%. But they found that there are some major confounding factors. If the patient is a chronic smoker, the nervous vessels are already compromised, and they found that the chronic smokers, the neurocognitive function is more. If the patient is diabetic, if the patients have hypercholesterolemia, so there are multiple confounding factors. But we should not consider this neurocognitive function solely by this radiation therapy. Rather, we should focus on this 6% overall survival at 3 years. That is the message over here. So this is already discussed. Again, back to Dr. F.M. Kamaluddin sir, the consolidation therapy. So even with this BID radiation therapy, with this concurrent high dose cisplatin etoposide, still the 5-year survival rate is around 30%. So how we can improve this outcome? So any consolidated therapy, any role of IO? Or better, I ask this question to Dr. Kudratullah sir, because probably it is his domain. Kudratullah sir.
Regarding IO immunotherapy, so far I know in limited stage there is no recommended data for using immuno-oncology. So till now it is not recommended, but in the extensive stage it is recommended only. Up to this, I can say.
So Dr. Jahangir Anam, you are a young medical oncologist, recently trained from India. So do you have any other opinion other than Kudratilai, sir?
No, I agree with Kudrilai, sir. There is some trials on immunotherapy, but no benefit. So I am not agreed to any consolidation therapy.
Okay, Dr. Joy?
I'll go no consolidation therapy or only
So-
immunotherapy for limited stage disease.
So only PCI and then on follow-up, right?
Yes.
Yeah.
Kamaluddin, sir?
So as Dr. Kudrathalai said that, immunotherapy is something that we are trying everywhere in adjuvant setup, consolidation setup. Unfortunately, there was some exciting data, but finally till now in limited stage, it failed. A very modest benefit of few months is creating big noise in extensive stage in immunotherapy, which is not that great like other stage. So overall, immunotherapy is not a great news in small cell lung cancer, but some excitement in extensive stage, but not for limited. There is no data to support to give limited stage immunotherapy in limited stage yet.
So let us see what we have so far as a consolidated therapy. You could see the stimulated, right? This is the French and English combination trials. After the what we have discussed, that the convert trial, they have followed the total procedure of this convert trial, 4 cycles concurrent CTRT with 45 gray BID radiation therapy dose. After that, those who are stable disease or responsive group, completion of the PCI, and after that, they have divided in 2 arms: induction, nivolumab, ipilimumab, 4 cycles, followed by nivolumab 1-year maintenance course, and other one is observation. Here, this can see that giving the consolidation therapy EP-nivo, the grade 3 pneumonitis is quite high. You could see that the pneumonitis is quite high than the observation arm. So the toxicity is high, but the focus of the study is the progression-free survival. Here you can see the PFS, that is the main outcome of the study. Nivo EP, the median progression-free survival is 10.7 versus observation is 14.5. So observation produced better outcome. But the interesting thing is you can see that the overall survival, still it is not reached. It is analyzed in this 2021 June. So the observation is 31.6. But up to 24 years, you could find these lines are below the blue lines, that is the observation arm. But after that, 36 years and upward, you could see the certain percentage of patients are sitting above the observation line. So probably there are few groups who can be benefited from this immunotherapy by this combination therapy, but we really don't know who are those groups. But they are trying to find out these groups. You could see the study, they have tried to find out a biomarker. They are trying to biomaterial, whole blood, frozen plasma, serum, and every time they're trying to find out the biomarkers. So probably with the stimulate trial, we could find out a specific biomarkers group, and we can decide these are the groups who can be benefited from this combination consolidation therapy. But still, we don't have any data that can guide us to use this consolidation therapy. Yes, you are very right. Right now, we don't have any options for this immunotherapy. And this is another trial. You could see this atezolizumab. It is tried from the very beginning, from the concurrent CTRT, and they have in the accrual phase, probably to up to 2023, they have to acquire these patients. So these are the progression so far. Chemotherapy alone, less than 10 months. Sequential CTRT, 10 to 15%, concurrent CTRT, BDRT, convert. So we tried to follow this convert trial. So we have decided to treat our patient with this protocol, concurrent CTRT, BID dose, cisplatin 25 milligram per meter squared day 1 to day 3, etoposide 100 milligram per meter squared day 2 to day 3, RT 45-30 gray, completion of radiation within 19 days, RT started from day 22, and PCI after completion of CTRT. This is the prescription of our patient. So is there any role of surgery, particularly for small cell lung cancer? This is our last topic of discussion. Pudrutilai sir.
I think up to stage 1A, we can go for surgery. But regarding this issue, knowledge is inadequate. I have not seen. But stage 1B onward, surgery may not be feasible for the patient.
So
And
at-
outcome is good.
So there was a time, if you say that surgery is possible in small cell lung cancer, you were probably going to fail in that examination. So there is a
Yes.
time, but last few years time has changed. And so there are few groups, even in the small cell lung cancer, when you can consider this surgery. So Dr. F.M. Kamaldeen sir, can you please say a few words? Is there any role?
There is a role, T1, T2, N0, M0, but the challenge is to get that patient, because in statistics, only 5% of the patient of small cell lung cancer will be in that stage. So if you get that, you can do surgery. And even there are some recommendation, you can do induction and surgery, or surgery followed by consolidation, like small cell lung cancer. And this, interestingly, the small cell lung cancer after surgery, survival is great. It is more than 50% survival with surgery. So when I first read it, as you said, it was surprising. But the message is, yes, if you can really find it. But the important thing is, like any radical treatment, you need to be very sure that you are dealing with T1, T2. There is no occult thing anywhere, because doing a surgery, then failing in a liver or brain or bone will be a disaster. So this is very important to critically stage the patient. If it is really a T1, T2, then you can do surgery. Not only surgery, radiation people, I can say, there are data that you can do SABR also.
I'm coming later. So you have option for that.
Shimon,
So-
I have a question to
Yeah,
Kamal
please.
sir.
Yes.
Please.
Sir, have you ever been seen T1, T2 in small cell lung cancer?
I saw one patient. I counseled him very well that there's a big survival, and I lost the patient.
Okay, so this is also evident here that all those scientists over the world, they have finally found 65 patients only, those who are treated with this surgery, and they found that if the patient is in a stage 1, you could expect a better overall survival, definitely very better overall survival. And they finally conclude that stage 1 patients could be the best candidates for surgery. Stage 2 and 3, probably they are not the very good selection. So if you really find a stage 1 patients, you can consider if our other parameters allow you to suggest surgery. So the NCCN guidelines regarding the surgery, T1, 2, N0, M0, preferred option is lobectomy. Patients should undergo post-operative systemic therapy, whatever the status, T1 or T2, anything. With N2 or N3 disease, unlike the non-small cell lung cancer, here is a definite role of port. Even with the N1 disease, we should treat our patients with port even after surgery. Benefit of PCI is unknown in these patients for a complete resection for T1, T2, N0 disease. So if the patient is treated with surgery after that radiation therapy with the regional nodes, probably they might be the candidates that we are talking about. Probably they should not be treated with PCI. What about a SABR? This is the specific question for Dr. F.M. Kamaldeen sir.
So as I was going to tell that when there is a surgery, there is a SABR in lung cancer. So like non-small cell lung cancer, in small cell lung cancer also, there is a proven role of SABR, not a big data as you say, but they have shown that the survival is comparable. And if you can really select the T1, T2, N0 disease, you can go for SABR.
So here you can see that the SABR idea comes from this CONVERT trial. They have found that those patients who are in stage 1, they have found only 4 patients from these 513 patients. They have done really better. You can see that 1 year survival 83, 2 years survival 79%. is a higher rate of overall survival. So from this idea, and there are still some data from the world. And finally, NCCN guidelines give some space for this SABR. For those, though the category is 2A, followed by systemic therapy, SABR followed by systemic therapy for patients stage 1 and 2A, who are medically inable, operable, or declining surgery. So there is a space for SABR.
So Shimon, there is a difference of non-small cell and small cell. In non-small cell, surgery followed by chemotherapy, but SABR not followed by chemotherapy. But in small cell, again, even it is a SABR T1, T2, you need to give consolidation chemotherapy. That is a difference.
Right. So small cell, you can escape systemic chemotherapy. So this is the all about the summary for limited stage small cell lung cancer. All the big guidelines are there. Cisplatin etoposide is still standard in combination with RT. IO is probably coming up. We really don't know. Progress has been made with RT. We should all convert to BD. So we should follow this convert trial. And role of surgery, still it is debatable. So thank you. Probably I have finished it within the design time, 4:30. So thank you all the panelists for their brilliant inputs and their fruitful discussions. So thank you so much. So I would like to request our scientific partners, Sanofi. So is there any representative from Sanofi? Yes,
I'm
please.
Professor Mufaddal.
Oh, yes, sir,
একটু
please.
কথা বলবো।
Please,
আচ্ছা,
sir, please.
about the PCI in limited
sir.
stage disease after chemotherapy and radiotherapy, you said it is 2 weeks, at least 2 weeks. What is
Yes,
the latest time? How if the patient is lost after 2 weeks and he comes back, say after 4 months, are you going to do that?
So this is a unique situation, sir. So no study but if the patient still in stable disease, or if
I think
we can found that there
I
is
read
no disease
somewhere,
progression,
I cannot give you
definitely
the
I will
reference.
consider for this PCI.
I cannot give you the reference, but I read somewhere if it is within 3 months, you can consider that. But if it is beyond 3 months, probably there is no utility. But even then, if you can go for an MRI brain and still you find that there is no metastasis already, probably you can consider.
So probably we can consider for escaping this radiation therapy, right, sir? We can avoid the PCI for these patients.
If the patient is with you within 3 months, then
Yes,
it's
sir.
okay. You go for it. And about the delayed attempt of radiation PCI, we should probably go for an MRI brain. Though in the
Okay.
early stage after completion of chemo and radiotherapy, you don't have to go for MRI. But if the patient reports later, probably it's better to go for a check MRI brain before you plan for it. In that
Okay.
case, it will
So
not be called
this is a
PCI.
very new. Okay, sir. This is a very new learning, sir. Thank you for sharing the information. So if the patients reported very late, then we need to check the MRI, and after that, if the MRI says it is okay, so if it is okay, sir, what we should do, whether we go for PCI or we will keep our patient on observation.
That will be called PCI. Yes, you can give, but still you can call it PCI. But if within this 3 months, or if the patient comes later, then there is MRI evidence of brain metastasis, then it's not PCI. It is just palliative radiotherapy to brain.
Of course, sir. Then it is, sir. Then it is definitely that is palliative radiation. Thank you, sir. Thank you for sharing your option. Okay. So Wasif, are you there?
So Shimon, if you excuse me,
Yes,
I
sir.
need to leave.
Okay, Kamal bhai, you are allowed to leave. So thank
Yes,
you.
sir.
Thank you for, yes, Wasif.
So thank you, Mr. Shuman Bhai, for your amazing hospitality and moderation. It was really great to be a part of this session where the country's leading oncologists are discussing cases of small cell lung cancer. So relevant cases versus treatment management were justified based on the guidelines, trials, and your precious experience. So I'd like to thank again Dr. Afoma Kamaluddin sir, Brigadier General Professor M.D. Kudrat Telai sir, Dr. M.D. Tawfiq Hassan Firoz sir, and Dr. Jahangir Alam sir for